Morning, everybody. We're so excited to have all of you here in person, and we also have a lot of people on Zoom. Um, this is one of my personal favorite times of the year. Under the direction of Dr. Peter Carroll and with the support of the department and the prior Makinich fellows, we established this endowment for the visiting professorship, really to recognize the incredible legacy that Dr. Makinich has created here at UCSF in teaching and in mentorship. And, for me, it's very personal. When I was an intern, and in those days we had no nurse practitioner, we ran the service. My favorite days were those when Dr. Makinich was operating, because I would get the call from Dr. Mack when he was doing a buccal urethroplasty to come down and harvest the buccal with him. And that was like the best thing ever for me. Me and Dr. Mack together, side by side, up in the mouth, the fellow and the resident down below. And it's fitting because actually Dr. Erickson, our visiting professor, was the fellow at that time. And I'm sure that it influenced my path into Reconstruction. But even throughout my residency, Dr. Mack was actually my mentor and treated me to wonderful lunches and dinners with great conversation throughout my residency and beyond. And as a testament to him, when I came back on faculty, he actually spent the first 3 months serving as a surgical coach for me when I was in the operating room. So he would sit back on a stool, not saying anything during my cases, and then afterwards give me tips and tricks on how I could have taught better, how I could have adjusted the bed better, set up retractors differently. And that is an incredible testament to this teacher who cares so much about people, about making the people around him better. And I know that we've all felt that here. So I'll let Ben introduce our visiting professor for this year, but just a round of applause first for Dr. Makinich.
Well, I'm really delighted, one, to see such a full room. This is great. And to see all these incredible people in this room together, because today's going to be a great day. And I'm very, very pleased to welcome someone who's actually, if you're allowed to have a best friend in urology, a very close friend of mine, Brad Erickson, who's the Reuben H. Phlox Professor of Urology at Iowa Carver School of Medicine. Grew up in Iowa. He was a star baseball player. Went on a full ride scholarship to Creighton, where he graduated magna cum laude of major in chemistry. He then went to University of Iowa for his medical school, Northwestern for residency, and then came out here for fellowship. And I came to the fellowship, we're the same year, same age. And actually Brad's took my spot. So thanks a lot. So I had to wait an extra year, but it was a good year. And of course I'm grateful to Jack, and I'm also grateful to Peter for giving me that opportunity to be here that year as a PGY7 and get a chance to know Brad and work with Brad. Brad then went on to become faculty at University of Iowa, where he's had an extremely distinguished career. He along the way got a master's in clinical research at Iowa, and he's been a really formative figure in the reconstructive world, and a thought leader and a research leader. He helped form this research collaborative that now has 25 people that you're going to hear about. Dr. Hampson and I are both members, and he's been president multiple times of it, but is really more than that, an organizational, but a kind of the intellectual force that drives the group forward. He's currently the director of functional urology and a program director for the GERS Fellowship at the University of Iowa, which has been a distinguished fellowship for the last 10 years. So with that, I'd like to welcome Brad to the
Thank you, Ben. Such a pleasure to be here. Thank you, Dr. Mack and Lindsay. Okay, so the title of the talk is The Oncologic Approach to the Study of Anterior Urethral Stricture Disease. What does that mean? Well, like a lot of you, you're in a high-powered academic institution like I was at Northwestern. The expectation, and a lot of people will go into oncology. A lot of my co-residents went to MSK, or they went to MD Anderson. And here I am thinking, I just want to cut urethras in half and, take out stricture and, as, kind of the lowly reconstructive urologist. But clearly, having Ben and Lindsay and Dr. Mack, that there's more to reconstruction than just cutting the urethra in half. The reason I title it the oncologic approach is that one thing that I was always a little jealous of my oncology colleagues is the foundation for research, the structure that had been developed over the last 40 years of being able to enroll patients into randomized controlled trials to be able to look at outcomes. That clearly wasn't the case in recon. But with Tern's group, with research that we've been doing over the last 20 years, 15 years, we've tried to create this foundation of study that we'll talk about here in the next few slides. Let's see. So thank yous. If you haven't seen this, I'll just quickly tell you what this is. This is the Makinich family tree. Blue is at 1990, Dr. Mack? 1990, first fellow. And then the last fellow is 2014. All the blue are his fellows. All the green are his fellows' fellows. All the red are his fellows that have fellowships. So it is quite the foundation. Like Ben said, I'm always I'm a step ahead of him. 1 year ahead. Of course, he's chair. I've done some work. I've been really interested in relationships, specifically relationships research-wise. And this is really cool software. I'm not sure if you've seen this, but Voss Viewer. I just was curious, like, who have I worked with? I've looked not only at individuals, but also institutions. You can see the University of Iowa and UCSF connection is very strong and remains so. And a lot of it has to do with papers that Ben and I and Lindsay have written together. This is where I had my first child. And it's weird. I didn't think I was going to get emotional, but this was one of the few nights that Ben actually took call for me. The other 345, I took call myself. But here's Oliver, our first, who's now, I can always know how many years it's been since I left UCSF because he's 15. It's been 15 years since I left. He was born on December 26th. There are the presents in the background that we didn't open because we left for the hospital on Christmas Day. And then here we are. That's my wife, Catherine. We're out at the beach when he's 3 days old. We have no idea. We think that life is great. Obviously lots ahead. Unbelievable mentorship from Dr. Mack. I'm actually going to try to make it to the baseball game this afternoon. I saw this quote, though. It just showed up on my feed a couple days ago, and I think this really talks about Dr. Mack. True teachers are those who use themselves as bridges over which they invite their students to cross. Then, having facilitated their crossing, joyfully collapse, encouraging them to create their own. This is Dr. Mack. In every sense of the way he lets us fail, he let us succeed, and he encouraged us to start our own fellowships, to take what we learned from him and say, you know what, we're not going to do it that way. We're going to do a little bit different. And, you encouraged us all along the way to continue to break down the dogma, break down the barriers of research. You guys know Greg. I assume many of you know Greg, but I did a lot of biking with Greg when we were here. Greg Tazian, who's now at CHOP. And then my son, Oliver, I told him I was visiting friends in San Francisco, and he said, "Dad, is it a work friend or a real friend?" I said, "It's a work friend." No, I'm just kidding. No, I said it's a real friend. It's a real friend. And, there's a big distinction between a real friend and a work friend, but Ben's definitely a real friend. And man, 15 years. This is Oliver at his first baseball game. This is Oliver pitching this year for his high school team that won state, and his brother that also plays on the team. So You're going to see what I've done from this point to this point. And it's been a lot of hours. So just one minor disclosure. I was the PI for Labry. I'm going to talk a little bit about Optilum at the end. Oncologic model for the study of disease, building this infrastructure of research through the TERNS group. And then I'm going to talk a lot about the idiopathic urethral strictures. Why? Well, I'll tell you, but the big thing is that most patients that have stricture disease, it's idiopathic. We don't know why they have it. Seems weird that we haven't really put a lot of work into figuring out the pathophysiology of the most common stricture. And hopefully we can shed some light on that today. So what do I mean by the oncology model? Elevated PSA, biopsy. So I went to Northwestern. I spent a lot of time with Dr. Catalona. I cannot forget prostate cancer. So that's always still my, still the basis of my thought. But you do the biopsy, you stage or classify the disease, you put it into a nomogram that tells you the outcome. You put it in the NCCN guidelines, it tells you what to do. You know, based on the staging, what the expected outcomes are. The NCCN guidelines also tell you how to follow up this patient. And then survivorship tells you what is the chance of erectile dysfunction, stress urinary incontinence. These are all things that took a long time to develop. And I talk about Sentinel papers. This was 1983. This is Pat Walsh's, Dr. Walsh's original description of the nerve-sparing prostatectomy. Only 16 patients, 100% negative margins, 100% erectile function afterwards. And I'm sure, I don't know if Peter can, what he felt about this paper, but the question was, have we solved prostate cancer at this point? And boy, 40 years later, we're still don't know what's going on with prostate cancer. And I'm not an oncologist. And I just pulled this paper from the New England Journal of Medicine. But 40 years later, here we are talking about how do you manage organ-confined disease, active surveillance, radiation, prostatectomy. Obviously, you could talk and wax eloquently about each one of those options for many, many hours. But the bottom line is here we have this Sentinel paper in 1983 that tells us that we can treat prostate cancer with good outcomes. And here we are still talking about it. The Sentinel paper for me for recon was this paper. And I know there was a lot that preceded this, but I was impressionable at this time because 2007, when it came out, I was thinking about going into recon. I'm not sure if I had matched or there was no match. I'm not sure if I had got the email from Dr. Mack yet. But this paper comes out from Eastern Virginia, 257 EPAs, 99% success rate. I mean, you could barely do anything successfully 99% of the time. And importantly, no ED. But when you looked at the paper, 60% of these patients didn't have any objective follow-up, meaning, and again, no knock on Dr. Jordan or any of the papers that preceded this. But what did that mean? Well, they hadn't shown up to follow up. What does that mean? It means they must be doing okay. Because if you don't follow up, then you must be doing okay. But there was no standardized way to follow to study ED. And so at that point, we're asking ourselves, have we solved urethral stricture disease? Can we fix all strictures with an EPA, send them on their way, and be done with them? Well, a lot of us had this inclination, this feeling that we had not solved it. So fast forward to 2010 at the US Grant Hotel, downtown San Francisco. This is where the AUA is. And this is the formation and the foundation of the TERNS group. And I was lucky enough to be asked to be part of this group, even though I was still a fellow. And you see in red, these were the original institutions, or not quite the original, but the original 10 or 11. As Ben mentioned, we have expanded. This was a meeting that we had at the University of Iowa. This is our mission statement that says we are going to be the best, essentially. And we've added Lindsay, so thank God. We finally we're going to have some work done. It's been a while. We're all like, chasing administrative positions. So we need you to push us forward. But we've expanded. There's 20 of us now. And I think the idea was that when people like Ben and myself were listening to those early talks at the AUA, with Dr. McInich, with Dr. Jordan, with Dr. Webster, with Dr. Wessels, these kind of grandfathers of recon, they would often present single institution retrospective studies. And we thought, none of us are going to be able to do these, accumulate enough cases to be able to present our own retrospective studies. So let's start combining our data. And that's what we did. And the foundation, at least my thought was, how do we study stricture disease in a standardized fashion? So we know that we've got the urethral stricture on the left with a retrograde urethrogram. We know on the right that this is a postoperative retrograde urethrogram. And the question is that a successful repair or not? And what's the best way to go from left to right? So this started the foundation of our study. How can we better assess going from left to right and asking, was this a success? So the easiest way to start, and again, none of these left to right diagnosis to survivorship for oncology started from the very beginning. For us, it started with the outcomes. Why? It was easy for us to compile our work as a group. So this is one of the first papers that we published as a Terns group. The important thing about this study was that unlike the paper I'd shown you earlier, our focus was on objective follow-up. We wanted to make sure that we had a defined outcome measure, and that was cystoscopy at 3 months and 12 months. So I don't care what the patient says if they're doing well. We're going to put a cystoscope in, and if we can't get it through the repaired area, then it's a failure. If it goes through, then it's a success. So what did we find? Well, you remember Jerry Jordan, 99% success. For our EPAs is around 97%. So pat ourselves on the back, doing pretty well. But follow that up with a 12-month cystoscopy. All of a sudden, we've gone from 97% to 86%. And our buccal grafts, 86 to 78%. And how hard do you think it was to get this paper published? Really hard. Why? Because what did the reviewers say? You guys suck. And they say, why do we care about your outcomes? Because we've got McInich's outcomes and Jordan's outcomes and all these people that I've mentioned already. Those are the guys that really need to be publishing on this. And I thought, quite the opposite. In fact, we are more representative of what outcomes really should be. And the other thing that we found, some really important things, and this also kind of provided some of the foundation of work that we're going to be doing in the future. Look at this urethra on the left. These are some made up numbers, but just bear with me. 3 milliliters per second. This guy is symptomatic. This guy on the right, 12 milliliters per second. He's now urinating 4 times faster than he was before surgery. We put the cystoscope in and we tell him failure. He's like, failure? I'm doing great. And in fact, 35% of our failures were asymptomatic at the time of cysto, and 50% of our patients didn't follow up at a year. Why? Because they're 28-year-old dudes that are coming in from 200 miles away. They don't want somebody to stick a cystoscope into their urethra. I mean, it's the last thing they want. So we had to pivot a little bit. But the other question was, maybe we are bad. And there's this, actually, Richard Santucci wrote this op-ed, or this opinion about this article, and starts talking about the Stradivarius effect, which I had to look up. But Stradivarius is the violin maker that nobody can replicate. Nobody can do it as well as him. And he thought, well, maybe our outcomes are bad because we just can't be as good as the grandfathers of urology. So, that comment leads to an idea. How bad are we? So this was our learning curve paper. Now you see these all the time, but essentially what you're looking at on the x-axis here is 10 cases for each one of the Terns surgeons, and you can see that over time we get better for the bulbar, and for penile we actually get worse. And I'm not going to go too much into that, but I think it's because we took on harder cases. But we're going to forget that exists. All right. So But what we did find is that it takes about 100 cases to reach proficiency. And how do we define proficiency? A success rate, an anatomic success rate of greater than 90%. So 100 cases. What does that mean? 3 years worth of work before you reach this proficient level. So the comment was probably right. We probably aren't as good as these other guys, but we can get better with time. And it was also really important to me that we defined what a failure was, anatomic versus functional. Now, we use these terms now, but these actually didn't used to exist. But anatomic is, well, functional, first of all. Patient comes into your office. Are they doing well? Are they having any symptoms? No. Functional success. Put a cystoscope in. If it goes through, it's an anatomic success. And you have this quadrant, and the gold standard would be the A, functional success and cystoscopic success. But we know that there are some people that have a wide open urethra that are complaining of lower urinary tract symptoms still, or having postoperative pain or postoperative ED. So it's important for us as a group that every time we were going to publish an outcomes paper, that we kept all three of these in mind: the anatomic, functional success, and the patients that failed in either one of those areas. So Lindsay said she was spent a lot of time with Ben early on in his career, and probably remembers handing out 20 questionnaires to each one of our patients, before and after surgeries. Maybe you didn't go through that phase, but I think we didn't really have a lot of sympathy for our patients early on, or didn't realize how hard it was to fill out questionnaires. But we knew that it was important for us to define this functional failure, that we were going to assess patient outcomes, not just with a cystoscope, but also with questionnaires. So each one of these graphs represents a separate study. But a lot of people have lower urinary tract dysfunction and pain preoperatively. After urethroplasty, it gets better. A lot of people have incontinence. It's not just post-void dribbling. It's some of its bladder dysfunction from outlet obstruction. Also gets better. That might have been your paper, Lindsay, I think. Post-void dribbling. So we do worry about post-void dribbling after urethroplasty, especially with grafts. But a lot of men have it preoperatively, tends to get better. Anxiety, depression improves. And most people are satisfied. And the important thing about this satisfaction data is that satisfaction or dissatisfaction really is related to recurrence, but it's as important that you don't have postoperative sexual dysfunction. So that powers some of our work later on, because we know that even if they have an open urethra, if they're having ED, they are not going to be happy. So hopefully you're all using and are familiar with the USUM. This is a 12-year labor of love project, 15, I don't know, but it's 12, okay. But it started here. This is a lot of the qualitative work that Ben has been doing with another former fellow, Brian Volsky. This was the original description of the USUM, or the urethral stricture symptoms and impact measure. But we knew as a group that if we were going to continue to ask patients about their follow-up after urethroplasty, that we needed to have a stricture-specific questionnaire. So this was developed the appropriate way with qualitative interviews. I love this. This is from the paper. We wrote this question. I felt abnormal because it took me so long to pee. The patient's like, what does abnormal mean? I don't feel abnormal. And then we changed it to, I feel uncomfortable. And obviously that changes things. So it is important, of course, to talk to the patients. This led to a questionnaire that was validated and recently published, and now has really become the gold standard for monitoring urethral stricture disease. Again, a collaborative effort with the group. So I'm going to read this quote. This is, I think, before this next body of work that I'll describe here in a second. I think a lot of people would describe this stricture in a lot of different ways: long, short, multi-segment, bulbar, distal, and when you put all of those terminology into a paper, you can imagine lots of heterogeneity, difficult for us to be able to group outcomes of strictures that look like this when you're trying to classify it into a disease that is not well known or not well understood. So I'll read this quote. This is a NASA scientist. One thing scientists do is to find order among a large number of facts. So amongst a lot of heterogeneous conditions. And one way to do that across fields is versus biology, geology, physics, and urology. I don't think you read that. It's through classification. Okay. So you can't understand a disease until you can classify it. And good luck finding anything in medicine that hasn't been classified or hasn't been organized to be able to study it, because presumably when you're looking at a stricture like this, there are multiple different pathophysiologies, and it was important for us to be able to classify it into disease process. And again, stealing from oncology, T, N, and M. Why do we have T, N, and M? Each one of those is telling you the extent of the disease and also giving you some prediction tools about eventual outcomes. What are the three variables that we thought to be most important? Length of the stricture, location of the stricture, and etiology of the stricture. I'm not going to go into too much of this, but I'm going to show Ben's favorite picture. This is ultimately how we started to look at stricture disease by location. And a lot of this is powered on our clinical intuition. And what do I mean by that? Bulbar, proximal bulb strictures are treated different than distal bulb. Penis scrotal, which was S2A, is different than bulbar and penile. Penile alone is different than, say, fossa. And the ones that have multiple areas or multiple segments are different from each other and more severe. And what this led to is on the outside is all different shades of blue. And each one of those shades of blue is a different combination of L, S, and E. 147 different combinations. And you may think, boy, are there really 147 different types of strictures? The answer is probably not, but we're going to get into staging here in a second. But the point was, by classifying it and having clear identification of what strictures, how strictures look different from one another, that we had a really high cap value, so reproducibility. In other words, we were looking at retrograde urethograms and clinical vignettes, asked fellows, residents, and Terns members, can they classify this stricture the same way? And the answer was yes. So this has not been adopted as much as I'd like it to be, but it is starting to creep into most outcome studies for urethral strictures. I'm going to quickly just mention something about this. I think it really is important that we do our retrograde urethograms in a standard way. This is how I do it. I do a first one with a straight penis, second one with a bent penis. That bend is approximately where there's a demarcation between the bulbar and the penile urethra. And I know there's no real anatomic designation, but that allows us to then separate that bulb into proximal and distal, and then allows us to classify S1A and S1B. Okay, staging grading. So if you give a patient a TNM classification for their prostate cancer, many of them don't know what that means. But if you tell them they have a stage 4 cancer, they know what that means. Stage 3, stage 1, stage 2. This is something that has reached the general public, and people understand that higher stage means worse disease. And the question that I asked myself and that we asked as a group is, can we take the LSE and turn it into a staging system? So I already mentioned there's 147 different combinations of LS and E. The way that we started to develop this is we said, amongst those three components, are there general demarcations between outcomes? And certainly shorter are better than longer, bulbar is better than penile, static strictures, meaning strictures where you have trauma and there's healing, versus a stricture where you have lichen sclerosis or unpredictable blood supply like hypospadias. The more active strictures, that there's a demarcation there. We're able to put this into a staging system, which ultimately led to 5 different stages, 10 different substages. Okay, so this is great, and anybody could have done this. But for a staging system to be validated, staging has to mean something. Stage 1 must mean something different than 3, and 3 must mean something different than 5. So for oncology, the staging systems will change as outcomes change. So as there's better therapeutics, the staging system will change. Well, what's our outcome? Well, it's going to have to be some type of surgical outcome. So this is our bulbar strictures. This is functional success rate. And as predicted, going from 1A down to 2C, we see a decrease in our functional outcomes. But what we saw when we went into the penile urethra was that there was a lot of variation in the surgical outcomes. And I'm thinking, boy, all this work for naught. We can't really validate a staging system if it doesn't correspond directly to outcomes. But what we realized is that for strictures like this, L3, S2C, E6 stricture, right? So strictures like this, there's a lot of selection bias. What do I mean by that? Ben might do this with a 1-stage dorsal onlay. I might do this in 2 stages, and Lindsay might do this with a perineal urethrostomy. And obviously, if we take the same stricture and manage it 3 different ways, the inherent outcomes just based on the desire of the patient is going to change. And so if you look at the distribution of surgical subtypes based on the stage, you can see that as you get more complicated, there's more variation in how we treat it because we are responding to what the patient's wishes, what the patient wants for their surgery. And when you look at success rate by surgical subtype, as predicted, the surgery itself, you're not comparing apples to oranges or apples to apples, it's apples to oranges. So how do you do that? Well, we had to kind of fudge it, and we created something called the urethroplasty triad score. Max score of 3, functional success is 1, orthotopic meatus is 1, single stage repair is 1, and everything below that is somewhere between 0 and 3. And when we start scoring the patients and their outcomes based on those measures, in gray, you can see there's a nice linear decrease. And so we are seeing that stage 1A is different than 1B, is different than 2A, all the way down to 5. So we felt pretty good about this. I won't go into what each one of these stages mean, but I think if you were to just look at these strictures, you would say to yourself that each one of these is more complicated for various reasons. And now for the first time, we have the ability to not only stage this disease for the patients, but also for us to more uniformly classify the disease process so that we can do meta-analyses, so we can start bringing our data together. And this was just recently published last year. RLC curves certainly look pretty good. We validated this in a separate data set. This is Keith Rourke. He's at the University of Alberta. And we're in the process of doing this work now with the EAU Young Academic Urologist Working Group. Prognosis. I'm going to see if this works. So the other thing, I don't deal with a lot of prostate cancer, at least in the diagnosis stage, unless I'm at the VA. But when I am at the VA and I have a new prostate cancer patient, I will almost always put their data into a nomogram. And I'm sure that's just what all of you do. Could we do that for urethral stricture disease? And the answer is yes. I'm going to see if this works. Hopefully it works. Shoot. Do you know how I can pull this? Let's see if I can do this. What if I hit escape? Is that going to work? And if it doesn't work, it's no big deal. I'm on it right now.
Oh, you're on it.
Yeah.
Yeah. Let's try doing that.
Well, if it's going to be a huge deal, it's no big deal. Screw it. It's all right.
Yeah.
Okay, trust me. Okay, so what I'm looking on my screen, and maybe I'll show it to you, is our ability to have a patient go to this risk calculator, put in the L, the S, and the E, and not just patients, but faculty as well, or clinical or clinicians. And it's going to tell you what the most likely surgery is that you're going to have performed, what the likelihood of success is going to be, and then the likelihood of you having some of the postoperative survivorship issues that we talk about. Let's see. Sorry. There we go. All right, is Kevin here? No? Okay. Well, Kevin's an intern, right? Okay, so maybe he's probably doing general surgery. But I've been working with Kevin. This is one of your new interns, if you don't know him. And Kevin looks at this risk calculator that you guys didn't see, but trust me, it was awesome. And he says it's not very awesome, actually. I can do way better than that. And so, yeah, we've been working with Kevin over the last year to improve the prediction model. And Kevin is going to be presenting this data at the GRS meeting in San Francisco and is working again with this EAU group to validate this. And so, you know, combination of the staging system that we talked about, this risk tool, this is really, we think, going to be helpful for the conversations that we're having with patients about their stricture and hopefully improving ultimately the informed consent process. Okay, what about treatment? So I told you that when I was here in 2010, we had or 2009, it was just 2 years removed from Jerry Jordan's paper. Everybody was cutting the urethra in half. And why were they cutting the urethra in half? Because it worked. The outcomes were really good. But something that's always kind of fascinated me about surgery is that all of us change our techniques every year, just slight modifications. I think we often are criticized because we're not changing these in the setting of a randomized controlled trial, and yet we all change our techniques. Is it just for fun? I don't think so. I think we change our techniques because we can tell intuitively as surgeons, and we know that it's an art to begin with, but we know that we're doing it just a little bit better. And when we started to not transect the urethra and people started to teach us how not to do it, and we incorporated it into our practice, it was like, well, of course you shouldn't cut the urethra in half. You know, if any of you have been a part of those EPAs, and Dr. Mack remembers, well, you cut it in half and you've got these bulbar arteries that are pumping and they stop eventually. And the thought is that they recannulate, but man, when you learn how to not do it, you realize that that is the way to do it. And this was just a trends paper. And you can see that over time, we have, as a group, this is just to 2017, but we started doing fewer ventral onlays, more dorsals, and transecting the urethra less. And this is just data that I pulled up yesterday, but and not published. But in the TERNS group, 75% of our bulbar strictures are non-transecting, 90% dorsal. This is my data in the middle. I rarely ever cut the urethra in half, and it's about the same at UCSF, about 80 and 80. And why do we do that? Well, because intuitively we know, and we know that satisfaction is directly related to the lack of postoperative sexual dysfunction. And we intuitively know that if you don't cut the urethra in half, it probably improves outcomes. And sure enough, a handful of us got together and combined our data. The rate of postoperative sexual dysfunction is significantly lower in the non-transecting urethroplasties. I've got this video that I'm not going to pull up, but I've been really, one of my big things that I stress to my fellows is to minimize the amount of dissection and work that we're doing in the perineum to decrease some of these postoperative issues like pain, erectile dysfunction. And so we can certainly, you can pull that up later if you like. But in my thoughts are that you rarely have to cut the urethra in half. This is the first paper I wrote with Dr. Mack. This is the first paper where Ben asked me if he could be a co-author. I mean, you don't get 300 publications without asking people to put your name on it. 500, yeah, exactly. But the question was, how do you best follow up these guys? I mean, we know that people don't want to show up for their cystos. So within the TERNS group, I said, well, maybe the AUA symptom score. Well, if you know anything about ROC curves, this is all the questions in the IPSS. None of them are anywhere close to or anywhere that would discern stricture failure versus success. So why is that? Because most of them are asymptomatic. Uroflow is a little bit better, but ultimately what we found, and this was really Ben's work with fellows, was that the most important thing is to put a cystoscope in one time at 3 months. And if it looks open at 3 months, it's most likely going to stay that way. And this work, again, turns work, but fueled by an individual, Ben, 3 months cysto has really become the standard of care. And I think that after urethroplasty, if it looks good, then that's all we need to do. Okay, so I am always a little bit jealous of our oncologists, again, because they have pathology. I every once in a while I'll get to read a path report. I love reading path reports, but I don't get to do it very often. But I decided, well, let's read some path reports for urethral stricture disease. And so this was just like on a hunch. I said, I would send off tissue, and sometimes it would say fibrosis, sometimes it'd say inflammation. Like, what does this actually look like under the microscope? I'm not going to go into this too much, but these are idiopathic urethral strictures. And I want you to look at the retrograde urethrograms. All of them look relatively similar. But when you look at the actual tissue underneath the microscope, a huge range. I would say on the left, it's basically just scar tissue, no inflammation. On the right, that's basically an abscess. And somewhere in between, varying degrees of chronic inflammation. So why is it important that it's chronic? You would expect acute inflammation after an injury, but chronic, persistent, chronic, lymphocytic suggests that there's some type of antigen presentation continues to happen in this area of the urethra. And it got us thinking enough that we decided to write a grant. The audacity of a bunch of reconstructive urologists to put in an NIH grant. But sure enough, 5 of us, including UCSF, wrote this grant. And our thought was that inflammation is the key to understanding urethral stricture disease. So this was a 2-year R21, $500,000, distributed to 5 different centers, asked a bunch of proms, took a bunch of tissue, got a lot of serum, and then followed these patients up. And our original hypothesis was that the pathophysiology would be predicted by the inflammation that we see in the stricture. And the focus of the grant was really on lichen sclerosus, because those are the worst strictures, the hardest to treat, and also the ones that we assume to be the most inflammatory. And again, using our classification system, you can see that most of these so we separated into 3: trauma, idiopathic, lichen sclerosus. The majority are idiopathic, as we know. The locations of the strictures are really based on pathophysiology. But we thought for sure the lichen sclerosus strictures are going to have the most inflammation. But what we see, all the colors, without going too much in this, all the colors represent inflammation. You can see that the idiopathic strictures and the lichen sclerosus strictures under the microscope look almost exactly the same. And in fact, from the pathologist point of view, idiopathic strictures were indistinguishable from the lichen sclerosus strictures. So there's something going on that we still don't quite understand. Some type of antigen presentation that is causing these strictures to either develop or at least propagate. The second hypothesis was the systemic inflammation is going to be associated with the stricture inflammation. And so we took serum and we did a big panel, and we thought, well, certainly the inflammatory stricture is going to have higher levels of systemic inflammation. And it's actually not what we found. There was really no correlation between systemic inflammation and stricture inflammation. But what we did see is comparing the serum inflammatory and fibrotic markers of the stricture patients versus the controls, big variation. We see that IL-9, PDGF beta, CCL5, all cytokines that are associated with inflammation or with fibrosis were all higher in the stricture patients versus the controls. So what does that mean? Well, we really thought that this was going to be a study that told us how to better treat lichen sclerosus strictures. But what it led to was us being more and more interested in these idiopathic strictures. And why haven't we done anything about them in the past? The big thing is that most of them are mid-bulbar, 1 centimeter. You can fix them and get them on their way. And so there's not a lot of interest in figuring out a stricture that can be treated so easily with surgery. But I kind of beg to differ. I mean, if somebody develops an idiopathic stricture, I think we should inherently want to know why. It's the majority of men. We know it's heterogeneous. We've got these new treatments that I'll talk a little bit more about in a second, but the Optilum. And we now think that there's probably 2-hit hypothesis going on. And what do I mean by that? I think that there are predispositions. So, the mid-bulb sitting right in the perineum, and the thought is that there's repetitive trauma there. But obviously not every bike rider or anybody gets kicked in that area. Not everybody's getting strictures. So why do some people get it and some not? The thought is that there may be some predisposition to the healing, to abnormal healing of the urethra. And sure enough, when we looked at the Utah population database, this is a robust database, and most of this work is obviously done by the University of Utah. We see that first-degree relatives have a hazard ratio of 14 for idiopathic strictures, okay? Most of this work has been in like hypospadias and looking at congenital inheritance, but why the idiopathic stricture? And we still don't know, but we think there must be this 2-hit hypothesis going on. There must be some predisposition to abnormal healing in the urethra of this group. And so this is a nice thing about doing a big NIH study, is that we have all this stuff. We had all this whole blood that we hadn't done anything with. And I said, well, let's use the whole blood to do some genetic sequencing. So we took 28 samples, and these were all L1, S1A, E2. So these were the standard mid-bulbar, shorter idiopathic strictures. Now, some of you are familiar with GWAS. You need thousands of patients to do a good GWAS study, but you can do these machine learning kind of targeted analyses. So you kind of go into a GWAS study with an a priori hypothesis. And ours was, let's look for pathways that lead to inflammation, fibrosis, maybe androgen receptors, and congenital hypospadias. Let's look at those. All right, I'm going to pull these up. I have no idea what these means. Okay, so I'm just a urologist. I cut the urethra in half. But I want you to focus on what's in the red. So these are all genetic mutations that were way higher in this idiopathic stricture group than in the controls. And notice repair, inflammation, repair, injuries. So these are all genes that follow this pathway. And you may say, so what? Are we going to do like genetic intervention or gene therapy for stricture patients? No. But what we can do, people smarter than me, can figure out how all these genes are related. And the common denominator that we're finding, and this will be presented up in Minneapolis in a couple of weeks, is TGF-beta. Now, TGF-beta is a known primary driver of genitourinary healing and fibrosis. And in fact, a paper that Ben put my name on, thank you, of a systematic review looking at patients and studies that have been looking at urethral stricture disease genetics. TGF-beta is one that is implicated quite often. And in fact, one of the papers that was referenced talked about TGF-beta, CXCR signaling might become a potential target for urethral stricture intervention. So I'm going to go back to that in a second, but I want to summarize. So I asked at the beginning of the study, or in beginning of the talk, going from left to right, was this a success? Well, hopefully by now you would know that that really depends. So what can we do instead of just jumping right to the end and calling it a success? Well, we can classify it. L2, S1B, E2, stage 2B stricture. We can put that data into a risk calculator and tell our patient that they have a 98% chance of having a single stage repair, 80% chance we're going to do a buccal graft, most likely dorsal, and then give them their 5-year functional success outcomes. Show them how we're going to do this graft, and then put a cystoscope in at 3 months. If it looks good at 3 months, probably never need to see them again unless we give them the USUM and we see that there are still lingering functional outcomes, like pain or erectile dysfunction that we'll need to continue to follow. And then hopefully we'll obtain some pathology. Now, I still have no idea what to do with this pathology, but I do know that there is a lot of heterogeneity. And to me, that means there's opportunity for improving therapeutics. And what do I mean by that? This is the robust study that I was a part of. And I personally think that the Optilume works, but I think it leads to a lot of urethras that look like this. And I can tell you objectively, I've put a lot of cystoscopes in, and we call these successes. The outcome is reduction in retreatment. So my thought is a lot of what we're doing in these urethras is taking a 3 French urethra and turning it into a 10 French. But the interesting thing about paclitaxel is that it attenuates TGF-beta. The other thing, and this is just a weird thing, and Kevin's not here, but we have struggled with this for a long time, doing multivariate models in our urethroplasty outcome studies. Smoking is actually protective from stricture failure, from urethroplasty failure. And I was like, no freaking way is it protective. We went back and looked at all of our patients, and it mattered. It counted. Now, we don't know cause effect, but here's what we know about smoking. Smoking decreased the odds by 5 times. And guess what? There is actually literature in plastic surgery that says that smoking attenuates scar. It actually decreases the redness. It decreases the fibrosis in the scar. What does it do, though? It actually leads to, in urethroplasties, it leads to higher rates of leaks. So the healing is not as good, but the scar is less. And guess what? Smoking attenuates TGF-beta. How about testosterone? Lots of links between low testosterone or urethral stricture disease. And in fact, in our group, we saw that free testosterone was lower T, higher TGF-beta. Can we block it? Again, this is not the focus of this talk. The answer is yes, but nothing commercially available. And so our lab, and I say our lab, mostly the 2 people flanking my picture here, are looking specifically at that. Are there ways that we can attenuate TGF-beta with commercially available drugs? We've given TGF-beta to human urethral epithelial cells. We've induced a fibrotic response, and we're currently looking at how does testosterone, how does flumamast, which is PDE4 inhibitor, which is commercially available drug that you can use for pulmonary fibrosis, how is that going to potentially change urethral stricture? And the way that I would look at it being used is that you're not going to take testosterone and your stricture is going to go away, but you might dilate the stricture and then make sure that they've got their testosterone replaced, or you put them on something like romiflumast, and that may decrease the risk of it recurring. Luckily, PDE4 in the middle, it's expressed all throughout the urethra, and we're in the process of kind of doing some phase 1 lab studies on the use of these drugs. So I'll just conclude. That's 15 years of work. You remember that picture of me holding Oliver. Lots of nights, lots of weekends, lots of meetings with the Turns group. But I believe we certainly haven't solved urethral stricture disease, but I hope that I've convinced you that we've created this foundation for next group, you guys, to study stricture disease in a little bit more of a uniform fashion. I'm a strong believer that pathophysiology is going to lead us to more patient and stricture-directed treatments, a more patient-centered approach to stricture disease. Lindsay's super into this. I'm sure you've done research with her, Ben, as well. We want to make sure that the treatment that we provide the patient is something that they want. They understand the risks and benefits of specific surgical interventions. I think these principles that we created, I don't know if I have the energy to do another one of these for 15 years, but I think that we can expand these principles into other benign conditions like ureteral stricture disease. And we got to do some clinical trials. And I think we're primed to do it. And the expansion of the Turns group was specifically meant to do those kind of things. So push your faculty to do some clinical trials, okay? So I think I finished on time. And I want to thank you so much for having me back. What a special place UCSF is. I'm so jealous of you that you get to do residency here. But I appreciate it. I don't know if Dr. Mack knew in this picture that he was going to be such an influential person to so many people's lives, but thank you from the bottom of my heart for being who you are. So thank you.